balancing the risk and reward in anesthesia for neuro-interventions. To begin with, I must tell you that I have absolutely no conflicts of interest. Neuroradiology is something that is dynamic, rapidly evolving, and this is a specialty that provides critical services. In the last decade or so, we've seen so much cutting edge evolution in what they do, what they can do. Their entire spectrum of services has increased. It is an amalgamation between modern neurosurgery and radiology, which provides the patient best of the both worlds. And I think that is set apart from all of the other branches. This is a minimally invasive alternative. So this is for problems that either could not be addressed with surgery or would require too major of an intervention for patients who are already very, very sick. So this, for the surgeons or for the neuroradiologists, this seems like the golden bullet, this is what is the solution for everything else. And what is important to remember is that their scope is widening every day and their range of indications is also increasing. When we look at the scope of neuroradiological interventions, particularly where we are likely to be involved, you can divide them into diagnostic and therapeutic indications. The diagnostics ones include CT, where we could be required for standby for allergies. You could have MRI for uncooperative patients, those with claustrophobia, extremes of ages. Then the DSA, where we are commonly there for long, long hours, hold up all over there, for CT-guided myelographies and CT-guided biopsies. The therapeutic interventions are huge. There is like a huge array. You could have aneurysm, coiling, or embolizations, AV malformations, tumor embolization, epistaxis embolization, angioma treatment, carotid stenting, vertebral artery stenting. You name it, and that is what they can do. Not just that, the scope of neuroradiological interventions also has an overlap with what we do for a living, like where it has pain procedures also that they could be doing and where we could be involved. Now, when you look at this entire spectrum of procedures that are available, you realize that your presence as a present and mindful anesthetist, like Dr. Sujata very kindly said, is essential to be successful in this domain. So why do the neuroradiologists need us? They need us to provide comfort and analgesia, as always. They also require us for immobilization of the patient. Well, let me talk for a minute about why the immobilization is necessary. When we say DSA, it means digital subtraction angiography. So what they're able to do, what they're able to achieve through this is that they're able to create a roadmap of vasculature. And when this roadmap of vasculature is created by injecting a contrast dye into the patient, eventually, whenever they want to do the procedure, they're able to superimpose this image on the currently available imaging and then proceed. As a result of this, every single time when they do that, they need the patient to be immobile. Particularly so for the smaller vessels, the difficult to access vessels. They also need us to get a certain sense of hemodynamic control, which may be very tight in certain situations, which may be a little more lax in others. There are certain procedures that require deliberate hypotension, some others where hypertension is required, and some others where you're not allowed to move the blood pressure at all, and I will get to that point in a bit. Additionally, they need us to ensure that whatever anesthesia we provide, our patients wake up early. Our patients need to wake up early in all suites, not just the neuroradiology suite. But here it's all the more important because their GCS needs to be assessed very quickly so that we can figure out whether the therapy has really made a difference for them. So when we look at anesthesia for neuroradiologists, you realize that it's a very challenging field for anesthesiologists. Procedures are increasingly complex and sicker patients are brought on the table and even more complicated patients get included. As a result of this, understanding the pathophysiology, potential multi-system side effects of the underlying disease, cerebral protection strategies, and potential pitfalls of every chosen therapy become extremely important for somebody who's going to be practicing anesthesia in a neuroradiology suite day in and day out. So if I had to highlight the key challenges for an anesthesiologist who's practicing such anesthesia, they would be the fact that you have to do this in a NORA. It's very, very rare that you have an IR suite which is situated in the middle of your operating rooms. There is the radiation hazard that you have to deal with. There is the demand for anticoagulation. And then there are the contrast reactions and nephropathy. When we talk about NORA, we have to understand why it's a concern. Now, 30 to 40% of our workload is being done in NORA these days. Greater complications and deaths have been noticed in NORA regions. It is an unfamiliar environment. The staff is unfamiliar. The rescue equipment is either unavailable, it could be outmoded, it could be stored in places where it is not accessible to you. The light is dim. The equipment that they use is very bulky. Patient is absolutely inaccessible. This is an example of our theaters. Usually I would think that our theaters are designed for our comfort. Our hospital takes pride in saying that the anesthetists are involved in all of their decisions. But here, like you can see, my anesthesia machine is not visible at all. It is somewhere behind the screen. The patient's head is much closer. If something were to happen, if there were to be a catastrophe, if I have to make any changes at all, I have to be there right in the middle of the field of action and I have to make those changes. And what if I had to encapsulate what makes NORA difficult? I would have the 5 Ps. There is the patient. The patient is sick. The patient has more often than not never seen the face of the hospital. They are not admitted in the hospital because this is a NORA location. For a lot of these procedures, they just walk in as if it is a daycare procedure. So their pre-operative evaluation is done on the day off, right outside the OT. And these are patients who sometimes require a lot of optimization because they have aneurysms and they have other comorbidities. They're old patients. They're already at risk for so many other things. They may be unoptimized and they may be coming to a table. That's where the prehabilitation comes in. Then I've added the word priorities. I apologize if any of you has a spouse who's a neuroradiologist, but the priorities of a neuroradiologist never align with those of an anesthesiologist. If I were to give you a very simple example of an interventional radiologist, is that I had a huge mediastinal mass recently for a cryoablation microwave therapy. And this is inside the chest. And our radiologist insisted that they wanted the mass facing upwards so that the only normal lung that this child had would go downwards because this was what make their life easier. If that was not enough, even their OT arrangements are so that you're pushed into a corner where you don't have access to anything. And what they want is immobilization, what they want is apnea, when all of that may be very difficult for you to provide. Finding that balance is difficult. Then there's personnel. In addition to not having the support staff that is able to understand the requirement of anesthesia, you have to realize that particularly in training institute or even those when you're practicing, is that interventional radiologists are radiologists by training who have then chosen to do interventional radiology, which means that for the first 3 years after their MBBS, their training encapsulates very little patient contact except for what they have during ultrasound and reporting and positioning during CT procedures. Which also means that, terms that you would casually throw around in an operating room and expect the surgeon to understand may be a little difficult for them. So training your interventional radiologist to speak your language or understand your language is also another challenge that you have to take up. Then there is the preparation. This is the OT preparation also. Sometimes in the main operating room, you're able to change your plan of anesthesia. When you make changes to your plan of anesthesia or change your plan of anesthesia, you require where patient crashes and you have to initiate a CPR algorithm. All of that becomes easy because the entire system is geared to take care of it. Your OT is always prepared for a difficult airway. Your OT is always prepared for a crash. Here, the preparation has to be special. You have to ensure, because we're so particular about something bad not happening in NORA, that these rescue modalities may be either expired or outmoded or have been stored in some cupboard somewhere because these incidents are not so frequent. So when you have high-risk patients, that needs to be taken into account. And when I say prehabilitation, I'm not just talking about optimization of comorbidities. It also means that when patients come to you for major surgeries, you are in a position to advise them to do incentive spirometry, to undergo physiotherapy, to ensure that their movement is optimal. The procedures that you're about to take up are quite a few times in neuroradiology, they semi-emergent or emergent procedures, which means none of that has happened. So all the tools that you have in your bag to ensure that the patient gets better sooner are gone. And you have the patient to deal with and contend with. Let's move on to the radiation hazard. When we talk about the radiation hazard, what we have to remember is that this is a high dose of ionizing radiation. There is a direct radiation from the X-ray tube. In addition to that, there is leakage from the collimator's protective shielding as well. So when it reaches the protective shielding, it sort of reflects back and then creates another source of radiation. When you radiate the patient, the radiation scatters from their body and radiates the area around them as well. The risk of exposure is very high for proceduralists and for anesthetists. This on the right is a picture of how much exposure to radiation happens anytime a procedure happens. So if you look at the difference between the exposure that is created every time you do a procedure, it is astounding. And they have done a very nice thing, where they've converted the millisieverts into a chest X-ray equivalent. So every time you stand inside for a cerebral angiogram, you are exposed to the radiation for 300 to 500 chest X-rays. I cannot emphasize enough how you should that need to protect yourself. These, just for everybody's reference, these are the NCRP recommended doses for occupational exposure. So if you are practicing regularly in neuro-intervention suite, I highly recommend getting dosimeters issued in your name and using them to ensure that your exposure to radiation is safe. What is the recommended protective gear? Usually, when I was training or in a lot of whenever we've practiced before, the only protective gear available to the anesthetist is a lead apron, where the lead is sagging at the bottom, where you're not really sure about how much exposure you're getting. But it is absolutely essential to make sure that your lead aprons are up to date. They are checked regularly. They have more than 0.5 millimeters of lead, that you're wearing a thyroid collar, that you have glass lead screens. A lot of times we're under this false sense of safety, thinking that if I sit in the console room, when everything is fine, I'm going to be safe. But you need to ensure that your glass that is there, that separates the OT suite from the console room, is also infused with lead, that you are using protective eyewear, and possibly even the caps, that the lead enhanced caps, if you're going to be inside the OT for a long time. You have to remember that the dose of radiation that you get exposed to decreases exponentially with the distance from the source. Now, when we started training, we were told that the source is the X-ray tube itself. But when you look at it and you study into it and you realize that the patient is also the source, the collimator is also the source, and there is scatter radiation, you have to realize that you have to be away from the entire assembly, which sounds irrational given the fact that as an anesthesiologist, in a critically ill patient for a critical procedure where they keep asking for apnea, you're going to have to run in and out. So then I thought, let's do a literature review and see what is the actual exposure of an anesthesiologist in a neuro-intervention suite. I was surprised to find this really, really nice paper where they measured the radiation over the face, just the face, because that remains exposed, right? You can cover everything else you like, but your face remains exposed. At the most, you can have like classes, neuroanesthesiologists and neuroradiologists during diagnostic and interventional procedures. Now, what they did was they gave the same sort of protection to both, right? They gave leaded acrylic sheets, which are usually present in an IR. They made the anesthetist wear lead apron and a thyroid shield, and they did exactly the same thing to the interventionist, except because they were going to stand closer to the patient, they were given leaded glasses instead of the acrylic shield, which had side guards as well. Now, then when you looked at the exposure, you find that, as would be expected, for an anesthesiologist, the radiation exposure was 6 times higher if it were an interventional procedure as compared to a diagnostic angio alone. What is surprising is the exposure of the radiologist. It was twice as much as what it would be for an anesthesiologist for diagnostic procedure, but it remained almost the same even when they did a therapeutic procedure. Clearly, there was something that was very, very wrong in this situation, that, they could perform a therapeutic procedure with the same level of exposure, but we could not. So they went one step further and they checked the number of interventions that were done by an anesthesiologist during the procedure. This is where the difference is, right? You have 14 interventional procedures. They're possibly giving relaxants, they're adjusting the tube stickings, or they're doing something or the other. They're adjusting ventilation settings through the procedures. And that number is 3 times as high. So you're doing 3 times as many procedures through an interventional procedure, and which is why you're getting exposed 6 times as much. If this is not a call for being careful in the IR, I do not know what is. We move on to our next concern, which is anticoagulation. Anticoagulation is rarely required in diagnostic procedures, more so in therapeutic procedures. This is to prevent thromboembolic complications, vessel occlusion. Usually what you use is direct heparin. Heparin, for that, we take the baseline ACT. Normal is 90 to 130 seconds. You make sure that you give 2 to 3 times the baseline. And the idea is to sort of get it back to normal before your patient is moved out. So you may require protamine at the end of the procedure, or in case there is a hemorrhagic complication. So that is something that you have to ensure. Now, this is something that we have found out the hard way, that usually you're able to get the ACT back to normal by itself. The way they time the procedure so that the ACT comes back to normal, the heparin stops acting. But a few times, even through shifting, the ACT remains very high and you require protamine. We had this particular incident where the interventional radiology suite, as is always, is located in a basement in the corner of the entire hospital. And we had so much trouble getting protamine because the only protamine available in the suite was expired. Heparin-induced thrombocytopenia is fortunately very rare, in such an amount of time that the patient spends in the OR is too little to actually generate it. Direct thrombin inhibitors can be used in patients who've already had HIT or are at the risk of HIT. This would include epiridine and bivalirudin. Antiplatelet agents such as aspirin and clopidogrel have also been used. And in exceptional circumstances, when things get very difficult, intra-arterial apsiximab can be used for thrombosis during an aneurysm calling. I have to admit, I have not done this yet. Then we move on to contrast reactions in nephropathy. They use about 300 ml of contrast per interventional procedure, which is quite a bit. So the patients who are at risk particularly would be those who are super old, more than 75, those who have pre-existing renal impairment with hypertension, diabetes, particularly with metformin use, those who are already dehydrated, which is quite a few of the patients who turn up for neurointerventional procedures, and co-administration of nephrotoxic drugs. What is the solution? Obviously, limit the dose of the contrast agent, use non-osmotic low osmolar agents, and have safer and optimal hydration. Now, the reason we are talking about this again is that these red flags may not be very, very clear to a radiologist. For you and me, when you look at this slide, you're like, oh, okay, this seems obvious. These patients are obviously at a risk of any sort of nephropathy. But because this may not be visible or very evident to radiologists, what you could do is either highlight these flags, or you could create a system where this is a red flag in general, and this is sort of communicated with the interventional radiology team upfront that all of these patients, you need to be careful. These patients need to be informed to us as such, so we can be a little more careful. There isn't too much of evidence that suggests that NAC or IV soda bicarb could be useful. And renal functions must be monitored for 72 hours post-procedure. This is again something that's very important because a lot of times these are daycare procedures. A lot of these patients, or they are sent off very the next day because nothing really happened. But monitoring of the renal functions is important. So these patients who are particularly at risk of nephropathies, we would advise hospital admission, continued monitoring for 3 days before their discharge, even if it is a minimally invasive procedure. There are other concerns, of course. One is the flush, right? So sometimes we've seen, long 6-8 hours procedures down, the patient is all puffed up. And we've not really given any fluids because there wasn't really any loss. Hemodynamics were maintained. The fluid is being given through the radiologist flush. Up to 2 liters of normal saline can be flushed through a therapeutic procedure. There is hypothermia. That risk is very, very high because it's not possible to really keep them warm. It takes special efforts. It's taken a lot of special efforts on our part to ensure that our radiant warmers are available even in interventional radiology suites, that we are continuing temperature monitoring as well. Now, we have to remember that this skull is closed here. Usually, when patients come to us for neurosurgery with raised ICPs, we're a little worried. But once the craniotomy is done, we know that part of our stress is over, that this is no longer a closed cavity. So the ICP is not going to increase any further, not going to cause further damage. Here, this does not happen. So there is an increased risk of ICP. What is even worse is that they're dealing with really small vessels inside the brain, which means that if there is a mistake and there is any amount of bleeding, until your radiologist tells you that's the case, the only way to figure it out is to look at your hemodynamic parameters and look for the hypertension bradycardia that becomes with the ICP. And the same is true about cerebral edema. With open neurosurgery, there is like that visual communication that's also happening with the surgeon within the brain and yourself. Then there is the transward. These are sick patients, sometimes on inotropic support, sometimes on vasodilatory support. They have to be transported to suites that are often in the corners of the hospital. And observation of clinical status after the immediate procedure is also difficult. You have two options. You either keep them in that corner of the hospital or you transport them back to your major recovery where they can be taken care of better, which necessitates early transfer of a patient who's just woken up from anesthesia, which may also be a little scary. Then you have the various lines and equipments, which are also very cumbersome and difficult to deal with. How do you conduct anesthesia in such patients? You need a thorough, obviously, patient assessment and evaluation. History is very important because you're looking at background events, chronology of recent events, which may not be as easy as it sounds because the patient may not have the medication to do so. You may not really have the time to elicit all of this history. So this has to be fast and efficient. You have to look for symptoms of raised ICP, document the current GCS because you need to know what the comparator is, what is the level of normal that you're going to get the patient back at. You need to assess the need for involvement of ICU, whether you're going to be able to extubate or not. Look at all the previous neuroradiological procedures, look at what trouble they underwent, and do an allergy and medication review as well. We need a focused neurological evaluation to establish the neurodeficit. You do need an appropriate end-organ evaluation of comorbidities as much as is available, as much as the time permits. If the patients have arrhythmias like they often do with a lead of an aneurysm, you may need ECGs and echoes, also those in patients with comorbidities. Among the investigations, you definitely need a CBC, renal function test for contrast reactions. Now, this when I'm talking about, I'm talking largely about therapeutic procedures. For diagnostic procedures that are an emergency, you can lower your threshold with regards to investigations that you require, but preoperative evaluation, optimization, and will be the same. Optimization investigations are something that you can sort of stagger where you do a CBC and RFT electrolytes only for patients undergoing diagnostic procedures, and then stage it so that when they come for therapy, everything else is done. With regards to prehabilitation, also see how much optimization of the comorbidities is actually possible within the time frame. Do that, get a diagnosis, and till the procedures plan, till the stents are being made available, till the coils are being made available, you get a day or two or whatever it is, and then you try and optimize their disease in that much period of time. We need the renal function test for the contrast reaction. Serum electrolytes are important because dyselectrolytemia can impact the GC. And with the normal saline being flushed, there is post-operative dyselectrolytemias are not very uncommon. We do need to rule out SIADH and cerebral salt wasting. Blood sugar levels need to be checked. You need an ECG. And most importantly, you need to review imaging. This is to assess the nature of the lesion and aid prognostication. This is something that we encourage very regularly, that anesthetists be able to read the scans on their own and not rely on the reports. This helps you. This helps you understand how difficult the procedure is going to be for them, how challenging it's going to be, how long it's going to take, what sort of recovery they're likely to expect, what sort of complications you're going to have, and then have an honest conversation with the patient and the caregivers and your ICU with regards to what the outcomes that are likely and with how much help you're going to require from the ICU. Then preparing the non-operating room. I've sort of put the non in a bracket because I wanted to emphasize that this is an operating room. Even if it is placed away from your main operating suite, this has to be prepared like a regular OR. The bulky radiological equipment may give you less space and less access to your patients. Because of that, you need long extension tubings, which puts an added burden on you because you need to make sure that none of those are disconnected through the procedure and you're unable to ventilate. So those connections have to be checked, available, and ensured that they are sacrosanct. Vascular access, you need to preempt the need for access because after that, the entire patient is going to get draped. You will have no access at all. Invasive blood pressures must be taken in patients who are at risk of hemodynamic instability or where tight hemodynamic monitoring is required. As always, there is like one small mercy that the neuroradiologists give us in this, which is that a lot of times they require an arterial access, in which case they're more than happy to allow you to transduce that. So if you are finding it difficult, this access can be established under local anesthesia and you can get the invasive blood pressure yourself. Monitors, even if it is not an operating room, you require the same ASA standards as you would in a regular OR. You do need ergonomic placement of the monitor, and we discussed it before about how the exposure to radiation is a problem. Because of that, it's preferable to have a slave monitor. You can be slightly far away in the downtime where no interventions are required and sort of monitor the patient from a place which doesn't expose you to radiation. Extensive airway evaluation is ideally recommended because you don't want surprises when you're the only anesthetist in that entire complex. Nobody is really trained to help you up. But in case it's not possible because the patient is already obtunded or anything, that remains a very real possibility. Because of this, standard and difficult airway equipment must always be available. Standard OT preparation, crash carts and defibrillators are absolutely mandatory in all of these settings. How do you choose an anesthetic technique? This is a question that's always there at the forefront of our minds. The sicker the patient, I don't really want to get involved. I don't want to put a tube. I don't want to be at a point where I'm, debating whether or not I'm going to be able to extubate. Is this patient going to wake up? What they have done, I don't really know. So because general anesthesia minimizes motion artifacts and allows apnea, that is like a field of comfort for the neuroradiologist. But MAC allows them to sort of have intraoperative communication with the patient so they can assess, then do the neurological evaluation on the table while the procedure is going on. A lot of times with carotid artery stenting, this proves to be valuable because you know what you're doing, whether it has worked, how everything is. This can obviously only be done in patients who are very cooperative and alert. And stroke and carotid artery stenting, this is the preferred modality. General anesthesia is used for longer embolizations and the works. Now, how do I ensure that I'm anesthetizing this patient correctly? The problem is that, your answer usually becomes BIS. I will use BIS. But the hypothesis is that, 40 to 60, even if you think about it, is a very wide number. And the stimulation that neuroradiology gives is very little. Like it is one pinprick that has happened. And after that, there is very, very little stimulation. It is not very painful. So if you keep the patient too deep, the patient is not going to wake up. If the patient is too light, the neuroradiologist is going to wonder if that additional source of breathing or whatever that is going to interfere with them. If you've given relaxant, you're always worried about awareness. So there was this study that actually checked the optimal depth for an anesthetic procedure in a neuroradiological suite. And they did BIS guided monitoring. So instead of 40 to 60, they had two groups. They did 40 to 49 and 50 to 59. The result was that the deep anesthetic group required more phenylephrine. Again, no surprises here. Obviously, deeper the anesthesia, more. And thing is that these patients are often, when their GCs are obtunded, they've not really been taking their liquids. They're far too dehydrated. So it's difficult to keep them up. The light anesthesia group, faster to spontaneous ventilation, which means that more often than not, they're going to keep telling you, oh, something is moving, you need to give relaxant. Eye-opening extubation orientation were way, way faster. But the incidence of movements was also very, very high. You had 6 out of 44 patients moving in this group versus 0 out of 44. So it's a tough choice to make. And also, BIS may not really be routinely available in a lot of our centers. This study was done in Korea where this was available. But even in our center, if I do want BIS for a patient undergoing an interventional radiological procedure, it would be a special thing because I would have to move my BIS monitor from the main OT suite to the interventional radiology suite. So should I pre-medicate? Unfortunately, like in anesthesia, there's no real answer to this. You have to have a tailored approach for each patient. Small doses of benzodiazepines for anxiolysis are pretty good. Like there is no real problem unless your GC is already impaired and it's going to add confusion and it's going to reduce the cooperation of the patient. Narcotics are best avoided because they can change the breathing pattern. And once the breathing pattern has changed, you're not really sure what you're looking at. H2 receptor antagonists and metoclopramide need to be given to sort of avoid aspiration. The main aim of the anesthetic procedure when you're giving general anesthesia would be to maintain hemodynamic stability, look at the cerebral perfusion pressures because you don't want those to change, and avoid blood pressure fluctuation. Once you've found your sweet spot, between you and the radiologist, and this is where we want the blood pressure at, 10% here and there, just that is what is allowable. Need for RSI needs to be assessed because a lot of these patients can be diabetics, they could be old, so they have additional reasons for gastroparesis apart from the fact that they may not be NBM. Airway control norm is usually intubation alone, no using LMA unless it's an emergency. Please consider you having something at hand for preventing a pressor response at intubation, either some opioid. Now, once they're intubated, opioid should be great. You could use lignocaine or labetalol or esmolol, whatever you're comfortable with. The key factors in deciding the plan of maintenance for anesthesia would be the patient condition. Obviously, if the ICP is raised, you use TIVA. Otherwise, you have a choice between TIVA and inhalationist. Whether you have the equipment and monitoring availability. Like I want to use TIVA, I want to use TCI for this patient, but if it's not available in my center, if it's not available in the IR suite, obviously it puts me at a disadvantage and then there's only inhalation. So I'm not going to say that, this because my TCI pump is not available in my interventional radiology suite, I cannot provide anesthesia. Then you have to sort of find the background, figure a way out to use it. Make sure you're comfortable with what you are doing. And obviously at the forefront is patient safety. So what are the advantages of both? With TIVA, there is hemodynamic stability. It avoids the decoupling of the cerebral metabolism. So, you're not worried, when the patient has raised ICP, this is the way to go. One would argue that propofol would cause hypotension, but when I say TIVA, I mean like a balanced TIVA where you're using either fentanyl or remifentanil infusions along with. So the hypotension is not really a significant cause of distress. You could choose to do it with or without paralysis. If you're using remifentanil, paralysis becomes just something that you use for intubation and then you can sort of do without it. But of course, because our natural training is through an inhalational technique, it becomes technique of comfort, technique of ease for us, ease for titration, etc. So this is something that needs to be done by somebody who's experienced. If this is something that all of us plan to do, I think, we need to start training ourselves in TIVA in regular cases, and then we can move on to a place where when the high-risk patients really come, we're able to use TIVA with comfort without really worrying that have I given too much propofol, is this patient not going to wake up, etc. With inhalation agent, the advantage is obviously the ease of titration, the comfort of use, how easy it is. Sevoflurane remains the agent of choice, but here, please remember, because we have to keep the MAC less than 1, you may have to get creative with regards to how to maintain depth of anesthesia. For post-operative analgesia, please, we need to make the plan in advance. Multimodal analgesia is required. You may ask me, is this really required? Because, just before I said, It's one single pinprick. But dural stimulation and tumor embolization can actually be painful. You have patients waking up crying with the pain. So, and then you don't want the ICP going up because the tumor itself has not been addressed. Only embolization has been done. So the chances of raised ICP persist even post-operatively. So you need to make your plans in advance. Analgesia plan must always be made in such a way that you allow early neuro assessment. I have a small cheat sheet. Basically, I've put together the specific anesthetic concerns for specific surgeries. I'm really sorry this became a super busy slide, but I thought that having everything in one go would be a little better. We look at the therapeutic embolizations first and what the concerns are that are required of the anesthetist. With therapeutic embolization of intracranial AVM, you will be required to give hypotension intra-op to make sure that they're not puncturing anything else. Post-procedure NPPB is a real possibility. Then there is therapeutic embolization of the dural AVM. Here, instead of hypotension, you want to provide hypertension. Deliberate hypercapnia is required so that the vessels become dilated and they're able to actually use them. Therapeutic embolization of extracranial AVMs require deliberate hypercapnia as well. For carotid cavernous fistula, you require the hypercapnia and the risk of NPPB exists. In addition to that, the ethanol sclerotherapy from an AVM or venous malformation could lead to brain or airway edema. There could be hypoxemia, hypoglycemia. Ethanol intoxication is a real risk because you're using ethanol for sclerotherapy, and even cardiac arrest. For cerebral aneurysm, you could have aneurysmal rupture, and BP control is vital. Balloon angioplasties for occlusive disease could lead to cerebral ischemia. You will require deliberate hypertension, and concomitant coronary artery disease could exist. So you have to really watch for that. Bradycardia is a possibility. Hypotension can exist. And cerebral ischemia and BP control remain primary in patients who have cerebral vasospasm, secondary to aneurysm subarachnoid bleeds. For vascular occlusion of giant aneurysms and skull-based tumors, you're going to require, there is a risk of cerebral ischemia and BP control will be required. For post-stroke thrombolysis, you could have intracranial hematomas and PPBs happening. Concomitant CAD may exist and BP control is vital. Extubation and recovery is obviously optimal because, like I said, while the disease is addressed, the disease still remains very much inside. It is not out. So you have to have smooth and rapid awakening that allows early neurological assessment. Endotracheal tube to LMA exchange can be considered for smoother extubation. Pressor response must be prevented as it was during intubation. Ensure a normal ACT to prevent any sort of bleed. Recovery often requires hemodynamic monitoring. Most diagnostic criteria and have to be met, and most of these procedures are usually daycare, like I said before, so you need to ensure that discharge criteria are met stringently before these patients are allowed to leave. What are the possible complications from this? Please remember that these complications can develop rapidly, must be managed swiftly. So they could be hemorrhagic in origin, they could be iatrogenic spontaneous, which are spontaneous, iatrogenic, or can be caused by anesthetic factors. Identified by recognition of contrast extravasation of physiological changes, occlusive because of thromboembolic events and misplaced points, urgent retrieval or lysis may be necessary. Vasospasm is likely. Now, there's obviously a move from the triple edge of hypertension to hypertension and euvolemia alone. Nimodipine is a good drug to use in these cases. You also have things like anaphylaxis, contrast nephropathy, hemorrhage at the puncture site, etc. Other possible complications would be delayed cerebral ischemia, focal neurological deficits or cognitive deficits, which can occur up to 4 to 12 days after the aneurysmal SCH. So this is something you just have to keep in mind. Magnesium, triple H, and statins have been used, but the only proven intervention is nimodipine. Hemorrhage is a little difficult because it may be difficult to figure out where it is happening. If it is a puncture site or groin hematoma, it's easy to see. If it is a retroperitoneal bleed that has happened further, it's not easy to see until the patient actually requires some form of resuscitation. What are your postoperative concerns? They arise from the bleeding, spasm, migration, or vessel thrombosis, which means that you require vigilant post-procedural monitoring and strict hemodynamic control. What we need to emphasize over and over to ourselves is that there is no difference in the care, in terms of the care, vigilance, and monitoring standards required for these patients as opposed to major open surgical procedures. To summarize, increasing foray of interventionists into complex procedures mandates comfort of the anesthesiologist. They'll achieve the world. They'll tell you that we can do this, we can do that, we can do that. But when they do that, they need an anesthetist who's comfortable on top of their game and confident with providing anesthesia to such patients. Peri-procedural physiological stability and recognition of potential complications is essential to provide sound anesthetic care. A well thought out plan coupled with rapid effective communication between the anesthesia and radiology teams is critical for good outcomes. Thank you so much for patiently listening to me.